The relationship among these three concepts is critical to our approach of how we're going about healthcare ethics here, so let's spend some time with them. I'll begin defining some terms. And morality we're going to talk about as distinguishing between right and wrong and good and bad. We'll keep it that simple, and it refers to our intentions and our behaviors. This is a definition I get from Rosemary Flanagan's Ethics Committee Handbook. She explains things very simply sometimes. Then we define ethics, and that is the process by which we determine the reasons for or against acting in a certain way. So you can begin to see how morality informs our ethical decision making. Religion, you probably have a pretty good idea what it is, but here's kind of an objective definition. It's belief in and worship of a superhuman controlling power, especially a personal god or gods. That's pretty broad and generic intentionally, so everybody can participate. Now we define healthcare, or healthcare, two words, it doesn't matter. I use them interchangeably. But it's everything that supports mental and physical health in all persons. Then we get finally to the topic of our concern, and we get to healthcare ethics. And healthcare ethics is exercising moral discernment as it relates to medical policy and practice, especially regarding controversial issues arising from scientific advances. All right, that's our foundation then. We can agree on the terms that we're going to use, and let's move forward with this. We begin by asking what kind of ethics then is it that we're talking about? Well, we're talking about Christian ethics, bioethics, Christian bioethics, but technically the terms are these. Medical ethics, bioethics, and healthcare ethics are used pretty much interchangeably, but they do have a history in their development. The original focus was pretty much called medical ethics. As seen, you can see in the second notch there, a term by Beecham and Childress. They titled their book Medical Bioethics. But medical ethics was simply the focus on the doctor-patient relationship, and paternalism was a substantial part of that. You remember when we talked about methods of consequentialism, this is one of the methods that we don't like so much, but paternalism is when the physician says, I know best, I'm going to make the decision, and the patient goes along with it. But as time passed, and especially as we went through the 60s and the civil rights movement, there was more focus on scientific advancements and research, individuals wanted to be more participatory in their healthcare decisions, and there was an increasing emphasis on autonomy. You can be my physician, and you can say, here's the options that you have. What shall we do? That lets me make the decision. And that's where we were headed, beginning in the 60s and into the 70s. I mentioned 3 books here that are important. Van Rensselaer Potter is the first one to use the term bioethics in his 1971 book. Then Beecham and Childress, who you hear me quote frequently, wrote the Principles of Medical Bioethics in 1978, and now just last year they issued their 8th edition of that book. Sometimes there are significant changes and sometimes not, but it does help fill up my bookshelves, and it does make money for the publishers. I also wanted to mention the Belmont Report and the Helsinki Declaration. The Belmont Report happened in the United States. We'll talk more about it later. It's related to the Tuskegee syphilis study, and it was all about the ethics of informed consent for those who are participating in research studies. The Helsinki Declaration is an international document listing out the principles of healthcare ethics that should be practiced by anyone everywhere. And you can see the date on the Helsinki tells you that it's been around quite a while, and it has been updated once. I can't remember the date on that update, but it was in the late 70s, as I recall. So healthcare ethics in the 21st century includes the full scope of healthcare delivery, including policy and practice. Everything is gathered under that term. Well, healthcare ethics is how we strive to answer questions like these. Is a physician morally obligated to tell you, his patient, that you are dying of cancer? Does our right to life entail the right to choose when to end our life? And that leads to a question, should assisted suicide, or what we sometimes call a physician-assisted death, be legal? It is now in 10 states. Is using non-human animals in experiments designed to benefit humans morally justified? Or on the other hand, is it imperative that we conduct such research in order to make advancements to care for human beings, even though it is more costly to non-human animals? We get down to the social issues of today. What is the best way to allocate healthcare resources? It was again in the news this morning when I was preparing this that they're still talking about trying to throw out Obamacare and come up with a new healthcare plan, and that's been going on for several years. It's hard to tell what will happen next, but it's certainly an important issue, and there are ethical implications all around it. It's not just a mechanical or administrative task. And we could even ask, although it's not been very prevalent lately, is human cloning acceptable? You might think of some others, and if we were in the classroom, we could talk about those. And in your discussion forum, you can mention if you think there are some others that ought to be considered. Hippocrates might have been considered the first medical ethicist, and he lived a long time ago, as you see there. We always turn to the Hippocratic Oath of do no harm, primum non nocere, do no harm. Interestingly, that phrase never appears in the Hippocratic Oath, but has been derived as the essence of that oath over the centuries. And over time, care of the sick has been influenced by religious and philosophical traditions that would build on the Hippocratic Oath as well as the Christian message of the gospel. I want to take time to note the Nuremberg Tribunal. It's what drew worldwide attention to medical research and the ethics of it. In 1945-46, Nazi leaders at the tribunal were indicted and tried as war criminals. Because there had been, you know this history, but there had been a systematic attempt by Nazis to exterminate European Jews. The euthanasia of useless life, they called it. The mentally ill, the incurably sick, eventually the Jews and the Romani, and nobody said no. There was no public outcry. And we're always startled when something so wrong seems to occur, and yet there is no large public outcry. What it reflects in this time was that during the years of the Nazi control of Germany, there was a pretty strong bias in Germany against Jews and Romani. A friend of mine whose family came from Germany said the prejudice against Jews was profound, and so it was an easy target to be made. And so that target not only made them be treated poorly, but they decided they wanted to try to eliminate them from existence, to purify the race. Interestingly, there is one physician, Joseph Mengele, who was doing experiments at Auschwitz. And the charges at the tribunal included his medical experiments. He was renowned for his research on twins. And as a result, 400,000 deaths, as far as we can account, came from his experiments. And he did primarily work with children, but these twins that he experimented with died from atrocious experimental procedures where there was little consideration for the welfare of the person being used in the study. And then these people were sent for execution when they were no longer useful. Just that one little study is in our history of why it's important for us to develop and adhere to medical ethics in research. There was a psychologist named Stanley Milgram at Yale in the 60s, and he decided to study this phenomenon in Germany. He asked why. Why were subjects willing to obey an authority figure in direct conflict with their personal conscience? And if he replicates that now in his experiment, Would Americans follow orders as readily as had the Germans in Nazi Germany? That's what he wanted to find out in 1961. Well, the subjects that he recruited were told, and they apparently believed, that they were legitimately delivering a series of increasingly painful electrical shocks to patients. Now, the shocks were purportedly to determine the effect of punishment on learning. And so the persons receiving the shocks, I called them patients, but the persons receiving the shocks actually were actors. And they were playing the role of learners who were trying to increase their learning through the shocks. But they weren't really receiving shocks. In a room next door and through a window, you'd see them yelling and protesting as though they were receiving the shocks, but they were not. It was all faux theater in order to do the experiment. And, what do authority figures look like? You remember at the beginning of the course, I asked you, who is your authority figure? Who do you turn to when you have an ethical issue? Well, in this case, they decided, just like the commercials do today on television, to put the experimenters in white lab coats. And then those experimenters in white lab coats, they didn't claim to be doctors, they just created the image, just like they do in the drug commercials on TV today, encourage these subjects to keep increasing the power of the shocks. Now, the subjects thought everything was on the up and up, and the phenomenon is that 2/3 of those people who were recruited to theoretically deliver shocks obeyed, to keep increasing and increasing the shocks, even while realizing that the shocks would eventually become lethal. And it's noteworthy, Milgram said, that many of the subjects were well-educated professional persons. So a quick summary of his finding: people can be persuaded to torture and perhaps even kill another person at the urging of an authority figure, even when it contradicts their personal moral code. Now, that's kind of ancillary to what we're studying, but since I wanted to tell you where the concern for informed consent in medical ethics really kind of originated, and it was in these episodes in Nazi Germany. Here's what he wrote in his book. He said, ordinary people simply doing their jobs and without any particular hostility on their part can become agents in a terribly destructive process. Moreover, when the destructive effects of their work becomes patently clear, they are asked to carry out actions incompatible with fundamental standards of morality. And when this happens, relatively few people have the resources needed to resist. I like to call that resource moral courage. They failed in their moral courage. And we see it today. Anytime we see some great injustice being done somewhere, or even evil being perpetrated, the people who are observing sometimes fail to respond to stop it because they lack what I call moral courage or moral fortitudes, what we called it years ago. Well, anyway, as I say, all of this with Milgram brought attention to the emerging field of bioethics through research. And so as we proceed, we see how morality, the sense of right and wrong, informs our ethics, which is making decisions. Moral theories help us identify the conflicts and contradictions in our thinking, helps us make more satisfactory moral decisions. So there are moral theories to help us. And in the Milgram study, so why did some participants resist the urging of the authority figure while so many obeyed? And as I've said before, I'm sounding redundant here, but it's because those who disobeyed were able to analyze it, to discern, and to give reasons for their action. Those who just went along with were not giving reasons. You remember Kohlberg's moral development theory? Remember stage 3 is where you just you want approval by everybody, and so you just go along to get along. That's exactly what was going on right here. All right, let's move to religion. Let's redefine it. I defined it very briefly at the beginning, but here's a more detailed definition that I like. A set of beliefs and practices about the transcendent. That would be God, known by a variety of names in many diverse traditions in the world. But it's a set of beliefs and practices about the transcendent around which a group of people organize themselves and commit themselves to a set of ideals. Those of you who are part of a church or other religious organization, think of if that definition pretty much tells you what that church or synagogue or Islamic center is for you. Now, our concern is that religion has a significant function in healthcare, and it plays a significant role for most people. Not everybody is religious, of course. Not everybody believes in God, of course. But generally speaking, these are the phenomena. We begin by noting that religion is concerned with the meaning of life, and people are always concerned about the meaning of life. One of the questions is, why are we here? Where did we come from? Now, religious faith, simply speaking, is the human response to God's revelation. That is, everything God is letting humankind know about God's self. We call that our human faith is the compendium that we put all that in. It's what we choose to believe about God. Theology, more objectively, is the critical study of God or concepts about God and the nature of religious ideas. Now, here's where it applies to healthcare. Religious or spiritual inquiry seeks to answer questions like, why do we exist? When and how do we live our human best? Why do we suffer, which historically is the question of theodicy? And what kind of respect do we owe to all lives, to all living creatures? Those are the questions that religion helps us answer, and which is why so often religion is linked to healthcare, trying to answer those questions in healthcare when you're dealing with patients who are extremely ill, suffering, or dying. These are the questions we want answered. But a more puzzling question is this. Does morality depend on religion? In popular thinking, morality and religion are inseparable. They are the same. Just consider, because clergy are authorities on religion, theoretically, they are also assumed to be authorities on morality. And because morally right is a matter of being commanded by God, and morally wrong is a matter of being forbidden by God. This is the divine command theory. So, it's right if God, it's right if God commands it. It's wrong if God forbids it. And this is a very basic way that morality depends on religion. But Socrates, clear back in the 4th century, struck this paradox. He asked, is conduct right because the gods command it? Or do the gods command it because it is right? It's a chicken and egg question, you understand. Does God make the moral truths, or does God merely recognize that certain things are true? Is it possible to have a sense of right and wrong without God? Those people who profess to be atheists or even agnostics, if they really have no reality of God in their lives, how do they make moral decisions? Or a way to put this clinically, if God did not exist, then child abuse wouldn't be wrong? Because if God is the source of morality, if there's no God, then where do we find our moral foundation? Now, I posit these questions to help you think through a little bit what people wrestle with when they're dealing with struggles and healthcare crises. Now, religion and particular moral issues, we have to ask, are there distinctively religious positions on some of these issues? And I take ones that maybe are related to healthcare, but I threw in an extra one, but abortion, for example. Most of the furor over abortion is informed by people with strong conservative religious convictions. Capital punishment, ironically for me, is that those same people are in favor of capital punishment. It's more progressive or liberal people who oppose capital punishment. But what about suicide? In healthcare, we talk about physician-assisted suicide. What about murder? What about different practices of sex? All kinds of different practices of sex. Are there distinctively religious positions on those? And would we have those positions if we had no religion? Once I want to pause and remember John Wesley, the founder of the Methodist movement. He said there are 4 ways that we learn about God. It is through Scripture, through the church, through experience, and by reason. All 4 of those things are important. And it's important to acknowledge that reason is part of that as well. We can think through these things. We don't have to have somebody tell us what to do. We can have a sense of what is good and what is right and think and apply on our own. Rachels and Rachels, here in the footnote, philosophers that wrote a book called The Elements of Moral Philosophy that continues to be a significant text. They wrote that every generation reinterprets Scripture to support its favored moral views. And I mentioned abortion earlier. They say abortion is but one example of this. We could also have discussed the church's shifting views on slavery, or the status of women, or capital punishment. I mentioned that also. Shifting views in the history of the church. Are there others? In each case, people's moral convictions are not derived from their religion so much as superimposed on it. To give you an example, I grew up and was ordained Southern Baptist. That's in another lifetime. But one thing I'm aware of is the Southern Baptists exist and they split, and the American Baptists separated from them over the issue of slavery. The Southern group did not want to protest slavery, and those in the other group wanted to start protesting slavery. And all of that happened around the time of the Civil War. So that's how churches and religious groups can change their views over time. Here's a moral conundrum for you. Conundrum is a difficult question to answer. Is human life to be judged and evaluated on the basis of its quality? Now, this is important because when we get into healthcare ethics, you're going to be trying to discern if a life is worth continuing. Is there a point at which we withdraw life support from someone because the quality of life is not sufficient to make it worth living? In advance directive documents, in some form or another, the question is always asked, describe what to you would be the basic quality, acceptable quality of life to you. In other words, you want this advance directive implemented to give medical interventions if you can achieve that quality of life. But if you can't get there, you want to be allowed to die. That's what it means. Well, there are 2 extreme positions on this theory, or they're kind of articulated through Catholic moral theology, but the absolute sanctity of life standard. Do you believe in the sanctity of life? And is it absolute? There's no doubting or denying it. It's not diminished in any way. If so, then whenever a life is at risk, all possible actions must be taken to save that human life, even if they have little chance of survival. We think in the triage process in disasters or in wartime that part of triage is setting aside those who cannot be saved, and so that the resources may be spent on those who can. The same thing's happening during the pandemic. We had this great concern over the availability of respirators, and every hospital was writing a protocol about who gets the respirator. That is, if I'm a patient, that I'm on the respirator, but it's real clear that I'm not going to get better, I'm not going to survive, is it all right for them to remove the respirator from me, allow me to die, so that they may give it to another patient who has a much greater chance of survival? That is the other side of the sanctity of life standard. Or do we believe, the absolute would be we always give all of our resources to save a life if we think there's any chance at all. Now, at the other end of the spectrum is what some authors call a totally lax quality of life standard. That is, they say human life loses all value when certain qualities are lacking. thus allowing treatment to be ceased or even active killing of a patient for trivial and even hedonistic reasons. If human life is, the value of human life is based on its qualities and on the quality of living, then as those qualities begin to diminish and recede from the individual during advanced illness, does that make it less and less important to try to sustain their life? This is the kind of thing that older adults really think about a lot. At what point is my life no longer worth living? At what point is it no longer worth spending so many healthcare resources on? Well, I mentioned divine command theory. Here's a little bit more to articulate that. It begins on the premise that God has told us, humankind, to obey certain rules, and we believe those rules are laid out in Scripture. God created humankind as free agents, and so we are able to choose whether we obey those rules or not. And we know that if it's commanded by God, it's morally right. If it's prohibited by God, it's morally wrong. And we also believe in this theory that you will be held accountable. There will be a judgment day. Interestingly, though, I return to Socrates' question. Is something right because God commanded it? Or did God command it because it is right? I want to take a moment to observe the ethical and religious directives for Catholic healthcare services. That's the little booklet that I asked you to read. You can get it online free. I gave you that address. But these are a good example of how religion-grounded rules are applied in healthcare. This booklet, and I hope you'll go through it in detail, this booklet has an opinion on almost every medical procedure that can affect life and death, the beginning of life, the end of life. And it uses deontological efforts, that is, that there are rules and directives here, but it also has a teleological effect. It is based on the outcome that is desirable. And if you go over it, you'll find out, for example, that there's one in there that says extraordinary care is not mandatory morally, but ordinary care to help a human being survive is obligatory ethically. Well, they explain at the beginning of the booklet in the introduction that these directives are all intended to mirror Jesus' healing mission. So it's redundant to say, however, it's grounded in Catholic moral theology. But here's the purposes that booklet was written: to reaffirm the ethical standards of behavior and healthcare that flow from the Church's teaching about the dignity of the human person. And I placed in there in parentheses, imago Dei. That is, we are created in the image of God, and that's what gives us our sanctity of human life. The booklet was also prepared by the Council of Bishops to provide authoritative guidance on certain moral issues that face Catholic healthcare today, and actually that face healthcare in every domain today. It doesn't try to speak for non-Catholic organizations or non-Catholic persons, but I include it in any course I teach because I think it is the best articulation of how a religious group, and a very significant one, the Roman Catholic Church, attempt to provide directives for people who are looking for the Church's instruction in dealing with difficult issues in life. And this is all about dealing with difficult issues in healthcare. People want direction, and that's what this booklet was designed to provide them. So again, we get back, what is the relationship of religion and healthcare? Another perspective is to ask, how does religion lead to positive healthcare decisions? Can you think of ways that people will make decisions about their healthcare options because of what they believe religiously, because of their faith? On the other hand, we seem to be more concerned with this ethically. How does religion lead to dangerous healthcare decisions? And I give here 3 examples that tend to pop up pretty often in healthcare ethics. The anti-vaccination movement that started about 10 years ago is going to continue if we ever get a vaccine for the COVID-19. Those are people who believe they should not be required to take vaccinations. There are some people who still believe that it's infant vaccinations that tend to cause autism. And so many people are trying to say their children do not have to be vaccinated. And of course, the more people that are not vaccinated, the greater risk that implies for the entire population. We get everybody vaccinated, then we're not passing the same virus or germ around. And that's the theory that's working as we seek a vaccine for COVID-19. Well, another way that it's dangerous is restricted medical care, where medical care is withheld from somebody because they believe Scripture says not to give the medical care. And that's even refusal of medical care, reliance on prayer alone. Let me give you some examples I have. Jehovah's Witnesses, many of you probably know, do not allow blood or blood products to be put into their body. There's 3 scriptures here that they predominantly refer to for not accepting blood products. That means that if your patient is a Jehovah's Witness, they will only go to surgery if you agree not to do a blood transfusion. And of course, most surgeons, on the other hand, are saying, I'm not going to do surgery on you unless you agree to a blood transfusion. There are some hospitals that are friendly to Jehovah's Witnesses and work hard to accommodate their needs, and they understand the use of blood extenders. And they understand that most Jehovah's Witnesses do all this, saying, if it means I die, then I will die, because to use blood products would threaten my eternal salvation. So I'm not going to do that. But coming out of this, we have some questions. Is there a difference among these? A parent denying blood to a child? Is that different than an adult refusing blood for him or herself? And should any patient be forced by the healthcare organization to receive blood products to be eligible for medical procedures? Is it right for a hospital or even a surgeon to refuse to do surgery just because a person will not receive a blood transfusion? We know that most surgeons do not want to do surgery unless they think they are giving the patient the very best opportunity to survive and improve as the result of surgery. And so this belief kind of challenges that objective of the surgeon. One case that I found interesting is Fosmeyer versus Niccolo. This is a case when a pregnant woman, a Jehovah's Witness, did not want blood transfusions, and she was pregnant. But she said, even despite the risk to her fetus, no blood transfusions. The court said, the patient, as a competent adult, has a right to determine the course of her own treatment, which included the right to decline blood. The Supreme Court did not claim that that fetus is yet a human being with its own autonomy, its own rights. There are some states, like the state of Missouri, that says that a fetus from the moment of formation is a human being. But the court, in cases like this, did not accept that view. Here's another interesting case that was shared with me. Madeline Newman was an 11-year-old girl in Wisconsin, and she died back in 2008 of diabetic ketoacidosis. And because her parents did not take her for treatment, they just prayed. And so the question came, was that parental abuse or was it neglect? If they were praying fervently and trusting God, was that parental spirituality or faith, or was it abuse or neglect? The police chief who had to handle that case said this, and he knew them because it was a small community. He said they believed, even though they knew she was ill, if they had enough faith and prayer, that God would heal her. They said it was a course of action they would take again. They firmly believed, even if they had taken her to a doctor, if this was the time God had chosen for her to die, she would die regardless of medical interference. Now he says these are not crazy people, but what they were saying was the medical intervention is irrelevant if God does not mean for it to be her time to die. The turnout on this was that both parents were convicted of third-degree reckless homicide. And this is a case of spirituality and faith apart from clinical medicine. where they're trying to provide all the care and they want to push aside clinical medicine. And the question we always have ethically is, do they have the right to deny that care to a minor daughter, child? Do they have the right to deny that care to an incompetent adult? What are the limits of this when we are exercising spirituality and faith in lieu of clinical medicine? Another case is one of childhood leukemia. In this case, within 24 hours of presenting to a small local hospital, a 10-month-old boy diagnosed with presumptive leukemia, that means they couldn't verify it yet, was transferred to an academic cancer center in a nearby larger town. So he was admitted on a Saturday afternoon. He was not acutely ill. He had anemia, but it was alleviated by transfusion, and his mother was present. And they also said at this time there were significant signs of tumor, but they couldn't characterize the cancer until Monday, when they had full laboratory facilities available. And then they could decide which chemotherapy would be the most appropriate. Well, as it turned out, the doctor went ahead and explained the baby's condition to the mother, and then when the father arrived later, explained it to him, and together they declined any therapy, any medical intervention for their child. They said they would put their trust in God. Now, part of their reasoning was the baby's great-grandmother had recently regained her sight after going to a healing service following a debilitating stroke. And so with that one anecdotal illustration, they believed they could generalize it to their child as well, that you put your trust in God, God can make it happen. And in fact, beyond that, they believed that the cancer treatment was irrelevant because it would fail. So they refused treatment and decided to take the baby to a healing service now rather than later. If they waited and allowed for the months of cancer treatment to find that there was no improvement, then it might be too late to get to the healing service. So let's go ahead and let God get on it now. They prayed for a sign from God just to verify. And the nurse's failure to start the IV on its first attempt was the sign, what they chose to accept as the sign that they were making the right choice. Now, as they discussed this and they tried to argue with the parents, the physician asked, why would God allow cancer centers to exist if prayer were a more appropriate mode of exercising parental responsibility? And the father answers, well, cancer centers are part of God's plan. So the children of parents who do not believe still have a chance. Well, then the parents were asked by the medical people whether they could muster a perfect enough faith to mediate the healing. And the answer from the parents was, a perfect faith is not necessary because they had a perfect God. They would hand whatever faith they have to God, and God would take care of it. The upshot was the child was discharged without any therapy, any treatment. They did not keep a follow-up appointment in the clinic, and the outcome was lost to historical encounter. They don't know what happened next. So what do you think? Did the attending physician take the right course of action by acceding to the parents' desires so easily? Should he have argued with them more? Should he have threatened them? Should other staff have been requested to negotiate with the family? Maybe a chaplain, maybe somebody who might relate to them better. Having been a chaplain myself, I can tell you they probably would not have accepted that chaplain because he was not a minister of their own faith. And so he was as wrong as the doctors were if the chaplain believed in the medical treatment over faith and prayer. Well, should legal remedies have been sought? Should they have gone to court to get a stay? So we ask, what are the limits of religious freedom and parental authority when a child's medical care is at stake? Does a parent have the right to allow a child to die without medical treatment because they believe God will take action? So, how would you respond to this case? From a deontological perspective, would you say there are certain duties that we have that must be fulfilled, and one of those duties is that we get proper medical care for our children, for people who are not able to care for themselves? Would you take a consequentialist perspective, saying, let's take the approach that has the best evidence behind it for producing a good outcome? Let's make an evidence-based decision. That's how we could approach it. But you see, religion seeks meaning in illness. That's why hospitals have chaplain, by and large. When people are ill, seriously ill, or one of their family members is ill, they ask questions like, first they say, is God there? Then what is God like? Then they wonder, is my husband's serious cancer, is that a punishment for some sin he did in his life? You can read the book of Job in Scripture and see that argument played out completely. Or people ask the theodicy question again. If God is all-loving and all-powerful, why is there suffering? Why must people die? Does God intervene to heal some people but not others? Why? And on what basis? And how can I even know that my beliefs about God are correct? If I'm wrong in my beliefs about God, does that mean God is not available to help me in this crisis? So ultimately, how does religious belief influence healthcare decisions? And it's all about the patients and their families' lives, religious lives, backgrounds, and we cannot change that in the brief moments that we have access to them. As I always told my students, my chaplain students in the hospital was, if somebody comes into the emergency room and they're losing a child who was in an accident and their theology just seems crazy to you, you cannot change their theology in that 30-minute period. Your job is to allow them to have their own theology and try to work with them in the context of what they believe. And that's a difficult thing to do, but it's the only appropriate and successful thing to do. Well, understand, religion informs our moral perspective completely. Even people who are not religious experience this because they live in a culture, at least here where we are now, they live in a culture that's still strongly influenced by religious belief, even though religious practice is on the decline. And here are the reasons. Religion is concerned with the meaning of life. We're responding to God's revelation. Theology, we're searching to understand why do we exist, when and how do we live our human best, why do we suffer, what kind of respect do we owe. Well, I've asked these questions throughout this section, and these are the ones that keep coming up. This is why religion is important in our morals perspective, and it's important when we are dealing with people in crisis in healthcare. There was a massive survey done back in 2015 entitled Religion in America. It was done by the Pew Research Center for Religious and Public Life. And they surveyed more than 35,000 Americans from all 50 states and analyzed the relationship between religious affiliation and various demographic factors. I add this here at the end because I just thought you might find it interesting to give you a little description of the current religious landscape in our country and how you might encounter religious beliefs and practices as they come to you wherever you are ministering or practicing medicine. Here's the percentage in our country in 2015 who identify themselves as Christian and the various categories of Christian. Non-Christian faiths accounted for 6%. There were unaffiliated, or what we call nuns. What is your preferred religion? None, they would say. So we have atheists, which absolutely believe there is no God. We have agnostics who say there may be a God, but there's no way it can be proved, and I'm not going to spend my time trying to figure it out. Or a lot of people who just say, I'm not even going to think about it. Just nothing in particular. And there are folks who are thoughtful, but they just don't know, and it puzzles them, but they just set it aside and once again don't put energy into it. So that leads me to the final question here. This is my last question. When you are dealing with family or friends or patients or clients, whose religious or moral beliefs determine what is right for everybody or for you? How do you deal with somebody who is sick, trying to counsel them, How do you accommodate their religious and moral beliefs and be available to them in that setting, rather than trying to impose what you believe on them? That's a difficult place for us to be in. Of course, as I teach this, I'm coming from the professional position as a chaplain, where I've seen it from that perspective more than any others. But I know that's where I dealt with people the most, is struggling how to accommodate religious beliefs that they don't agree with. So that may be your challenge, whether you're a clergy person or a physician or a nurse. This will be your challenge at one time or another, and probably often. Thank you.